Good morning, y'all. We'll start soon. I think we'll have some more people trickling in, so we'll give them just a minute. All right, y'all. Good afternoon now. My camera has decided not to work, even though it worked on the meeting before this, of course. You know how it goes with technology. But thank you all for being here today. I'm super excited for this presentation, and to be able to pass it over to Caroline. But before I do, I'm going to go ahead and go over some housekeeping notes. So today's Rural Health Seminar series. Sorry, let me introduce myself for those of you who have not met me. Benchmarking, critical access hospital gold standard benchmarking, reimbursement strategy sessions. There we go. So for those of you who don't know me, my name is Aspen Drood. I manage the Center for Rural Health and Nursing here at UTA. And so today's Rural Health Seminar series is going to be focused on a research done by Caroline King. She's an undergraduate honors BSN student. And it's titled Rural Texan Mothers Need Midwives, and it's a literature review of women's healthcare and inequities at the state level. Just for all of you to be aware, this activity is being recorded today. This is a quick disclosure to our learners. No individual with the ability to control the content of this activity has any relevant financial relationships with ineligible companies to disclose. No commercial support was received from any ineligible companies for this activity, and the University of Texas at Arlington's College of Nursing and Health Innovation is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. Our learning outcome for today is that participants will report an increase in knowledge about the maternity care crisis in rural Texas, benefits of midwifery-led care, and areas of research to address the gaps in care, as evidenced by 90% of participants describing at least one concept learned based on information presented during this event. The contact hour for today, you will be able to receive one contact hour if you at least attend 90% of the activity and you complete and submit a post-activity evaluation. That will be given to you via link and QR code at the end of the activity. So I will be sharing that at the end. And I'm going to go ahead and pass this over to Caroline. Let me stop sharing my screen.
All right. Hi, y'all. Can y'all see the presentation?
Yes, ma'am.
All right, awesome. Well, thank you, Aspen, so much for that introduction. Hi, everybody. So as Aspen stated, my name is Caroline King. I use she, her pronouns, and I'm going to be y'all's presenter today. Once again, thank you, Aspen, for giving me this wonderful opportunity. I've put a lot of time and love into this project, so I'm really pleased to be sharing it with y'all today. Thankfully, we've already gone over the learning objectives, so we don't need to go over that again. I would like to make a note on the use of inclusive language. I will be using terms such as client or pregnant client in order to be inclusive to all individuals who have the capability of growing and birthing an infant. I believe it is important to highlight this as it is a reflection of my own personal biases and preferences for how I want to present my work. Any statements that I make throughout this presentation are mine and mine alone. And I would like to also state that this presentation is not intended to disparage any particular medical discipline. Every member of the healthcare team serves a much needed and valued purpose. This presentation is intended to highlight a particular modality of care and the potential benefits that can be provided to a particular population in the United States. So a little bit more fun stuff. Who am I? Well, like I stated, my name is Caroline, and I'm currently in my first semester of senior year as an honors nursing undergrad. I started back at UTA in the fall of 21, but I wasn't brought on to the center until January of 23. I was hired for the primary reason of writing this lit review on midwifery in rural Texas. While that may sound pretty niche, it was actually kind of difficult to narrow it down to exactly what I wanted to share through this review. I began the process the following month in February, and I was thrown into, wanting to learn what a midwife is, the history of midwifery in the United States, and the cultural impact of midwives have had on. I'm so sorry. I made my screen big, so now I'm just kind of like, oh my gosh, wait, where am I? So that's my bad. The cultural impacts midwives had on pregnancy and childbirth throughout the centuries. I wanted to know as much as I possibly could, write down as much as I could, and then kind of narrow it down from there. I eventually settled on comparing client outcomes between midwife-led and physician-led care and the implications of scaling up the midwifery presence in rural Texas. So after many months of being on and off with the review, I submitted the article for publication in November of 24. About 3 months later, I received confirmation that the article will be published in the May 2025 volume of the Rural Nurse Organization's online journal for rural nursing and healthcare. I'm super duper excited for my article to be shared with the world, and I'm extremely honored to be published alongside some of Con High's own faculty. So. Now, getting into the nitty-gritty. What did I learn in those many, many months about midwives and maternity care in rural Texas? I'm so sorry. Well, firstly, Texas has a maternity care crisis. 126 counties in Texas are classified as maternity deserts, and 56 counties are considered to have low access to maternity care. The effects of the low access to maternity care are reflected in Texas ranking 37th in maternal mortality rates, uh, with 28.9 maternal deaths per 100,000 live births between 2018 and 2022. This is in comparison to, at the time, the national maternal mortality rate of 23.2 deaths per 100,000 live births. And when narrowing the lens, numerous studies support the fact that maternal and infant mortality and morbidity rates skyrocket in rural communities. Rural births are at a higher risk for maternal ICU admission and mortality than their urban counterparts. And although there are currently approximately 3,400 OB-GYNs practicing in Texas, only 4.4% of them practice in rural counties, which results in an estimated 52% deficit. And while the healthcare workforce is decreasing, the number of maternity units closing in rural hospitals are increasing. Between 2004 and 2018, 231 rural counties nationwide lost hospital-based obstetric care due to closures, with 27 hospitals in 22 rural Texas counties have been closed since 2010. And these numbers are only expected to rise throughout the next 30 years, with projections estimating a 31% OB-GYN deficit by 2050, and 75 Texas hospitals have been identified as at risk for closure as of June 2022. The workforce shortages and facility closures negatively affect the millions of childbearing people residing in rural Texas. It was found that a lack of designated local maternity units and increased traveling times are correlated with an increased incidence of postpartum hemorrhaging, intra and postpartum blood transfusions, delays in transfers of care, and adverse fetal effects. So, not very great. So, midwives, a potential solution? Sorry, I think that's funny. So researchers have found that midwifery-led care results in a lower incidence of medical interventions, higher rates of vaginal birth, increased client satisfaction, and a lower incidence of events contributing to maternal infant morbidity and mortality than physician or OB-GYN-led care. And really, the United States has begun to shift more towards midwifery-led care, with out-of-hospital births in the U.S. increasing from 0.87% of all births in 04 to 6.1% in 2017. And this increase in midwife-led care is despite an overall decrease of births per year in the U.S., with one study finding that births led by either a certified nurse midwife or CNM, a certified midwife, a CM, or an unlicensed midwife in hospitals have increased from 7.4 to 9%, and there's been almost an 8% decrease in hospital births from 03 to 2018. And so the demand for integrating midwives into the maternal healthcare system is evident, and especially in Texas. However, evidence suggests that due to limited options when selecting a birth attendant on a birth certificate, about 37% of Texas CNM attended births are incorrectly attributed to other providers. And so this suggestion, implies that midwifery in rural Texas is not fully understood nor accurately portrayed in other quantitative studies. And so with this presentation, I intended to compile the results of studies examining midwifery in Texas to address the need for more subject knowledge. And so this analysis will compare the maternal infant outcomes of midwives and physicians in the US and Texas and identify current gaps in the current literature. But quick interlude, I don't want to make any assumptions about anyone's knowledge on midwives and what they exactly do. So a midwife provides care during a client's pregnancy, labor, and postpartum period. Midwives attend births on their own accord and provide care not only for the pregnant client, but the newborn as well. The care includes applying preventative measures, promoting the natural birth, assessing and detecting complications in both client and infant, and accessing and transporting their client to other appropriate care in the event of an emergency beyond the midwife's scope of practice. And so there are three types of professional midwives in the US: the CNM, the Certified Professional Midwife, or the CPM, and the CM. Texas's governing entities regulate and allow the practice for only CNMs and LMs, which is a type of CPM. Again, a little confusing, but it is what it is. CNMs are considered advanced practice nurses, and meaning they must have their nursing degree and RN license prior to admission to a midwifery program, while LMs only need a high school diploma or equivalent before starting the approved program. And CNMs are the only, along with CMs, are the only professional or midwives with the professional qualifications to perform as a primary care provider for clients from adolescence to postmenopause, providing gynecological family planning services, preconception, antenatal childbirth, the whole kit and caboodle. CNMs can practice in all settings, although a majority of Texas CNM assisted births occur in the hospitals. The LM scope of practice is limited to providing services more to pregnancy, childbirth, and the postpartum period. LMs provide maternal and infant care through the first 6 to 8 weeks of life. And while a CM has the professional competency to order and interpret diagnostic tests, the only drugs they can administer without a physician's approval, and now this is my understanding and how I like to explain it, is oxygen and conjunctivitis prevention of the newborn, which I will say is not really what it is, but that's how I explained it. So midwife or licensed midwives can attend births in the hospital, but they usually assist in out-of-hospital births. And so, getting into the methodology a little bit, when I was looking at articles, I wanted studies that examined populations in the United States and were published after 2016. I didn't want to include any non-experimental studies like opinion or editorial pieces. And I will say there is that one systematic review, not really experimental, but it was really good. You'll see. And so in the end, I came up with 10 retrospective cohorts, 3 economic analyses, 2 cross-sectional studies, and 1 systematic review. And so jumping right on into it. So the presented 8 studies on the table compared the rates of cesarean deliveries in midwife-attended and physician-attended births. Researchers' data consistently showed that births led by midwives resulted in a decreased utilization of cesareans. 4 studies I do want to highlight are the Carlson 2017 study, Niels, Souders, and Wostens. The Carlson study studied 4 cohorts, one with a normal BMI under the care of a midwife or an OB, and then another with the same conditions, but for obese clients. The study found that the cohort of obese midwifery clients were 87% less likely to have a CD than that of their matched OB cohort. And I feel like this is important to highlight as clients of a higher BMI can be considered high risk. So these results suggest that midwives are capable of managing certain higher risk conditions. Neal's study observed delivery facilities that employed both physicians and midwives. They observed that those facilities had a 12% lower CD rate than facilities that only employed physicians. And so this implies that the increased integration of midwives into the healthcare system correlates with higher rates of physiological birth. And Souders' study observed that between 2014 and 2018, that nulliparous, meaning that this is the first pregnancy this client has had that exceeds 20 weeks gestation, nulliparous clients of midwives had a 30% lower risk of having a cesarean, and then multiparous, meaning that the client has had more than one pregnancy reach 20 weeks gestation, midwife clients were at a 40% lower risk of a CD or cesarean than their physician counterparts. And I just found that this study was unique. None of the other studies that I found presented the data like this, separating it into first-time parents into experienced parents. But I just thought it was interesting to that the data was presented in this way. And however, the biggest one, Wostens, was the largest cohort of any study discussed in this review, which observed over 13.6 million pregnancies between 2007 and 2018. And the results of this observation found that midwife-attended deliveries have increased by 33% from 8% of all deliveries in 2007 to 11% of all deliveries in 2018. And cesarean deliveries rates have decreased by 7% from 29% of all deliveries in 2007 to 27% of all deliveries in 2018. And so, as I had stated earlier, this data heavily suggests that, partly due to a central staple of midwifery care being to promote a natural physiological birth, that an increase in midwife-attended deliveries correlates with a decrease in cesarean delivery rates. And so, still in the promotion of a natural birth, midwives do not use means of intervention such as episiotomies, surgical instruments, or labor-inducing procedures to speed up the birthing process as frequently as physicians do. When it comes to perineal lacerations, that same Carlson study observed that obese clients of midwives were 76% less likely to sustain 3rd or 4th degree perineal lacerations than the matched group of obese clients of OBs. Another study reported that the risk of perineal laceration was 19% less likely in clients of midwives. One study stated that midwifery clients had a 30% lower risk of having a vacuum-assisted birth than OB clients. Another found clients under the care of an OB were almost 3 times more likely to have an operative vaginal delivery by means of forceps or a vacuum. And overall, I had found 6 studies that analyzed the use of oxytocin and labor induction slash augmentation. Over 2.5 million pregnancies were analyzed, and it was found that clients under midwife had, on average, a 52% less risk of being administered oxytocin or undergoing labor induction slash augmentation. In a similar vein with medication, clients under the care of an OB were found to be 24 to 69% more likely to be administered an epidural or anesthesia during labor. And while pain management is an extremely important aspect of labor and delivery care, there are potential risks to the client and infant should an epidural be utilized. So, and shifting a little bit from maternal outcomes to infant outcomes, there was a 2016 study that developed the midwife integration scores, which measured, well, midwife integration into the healthcare systems and maternal infant outcomes. It was found that states that integrated midwives more into maternal healthcare had higher rates of spontaneous delivery, vaginal births after cesarean sections, and breastfeeding success rates at birth and 6 months, and then lower rates of cesarean deliveries, preterm birth, low birth weight, and infant mortality rates. And then there were 2 other studies that found that clients of midwives had a 29% decreased risk of having a preterm birth. And now, once again, shifting our lens, let's talk about the money. In 2019, low-risk midwifery clients paid, on average, $2,226 less than low-risk OB clients. The researchers attributed this cost difference to lower rates of preterm birth and episiotomies. Episiotomies? Yeah, I said that right the first time. Which are both less common under midwife-led care. 2 other studies compared the cost of out-of-hospital births to hospital births. It's estimated in 2021 that an uncomplicated vaginal out-of-hospital birth averaged around $4,650, while an uncomplicated vaginal hospital birth averaged $12,156. If out-of-hospital births had increased by 10%, that would have generated almost $11 billion per year in savings without compromising client safety. And so there was this 2022 study I found that examined the shift to midwife-led care in Texas, when 324 women of childbearing age in El Paso were asked to compare their birthing preferences to their actual experiences, along with questions that explored their feelings about previous care. Clients reported that being able to be involved in the decision-making process, having their preferences respected, and having their birth attendant being the same person who provided prenatal care as extremely important to them. This study revealed that a woman felt, quote, a sense of pride in the ability to bear children physiologically, end quote, and, quote, regarded midwives as trustworthy and able to value a mother's goal for her childbirth, end quote. When asked to describe their experiences with physician-led births, women identified constant themes of feeling ignored in the decision-making process, birthing requests being denied or disregarded, and a overall lack of individualized care. A 2018 review, the systematic review that I mentioned, can further expand upon these themes. By synthesizing qualitative data describing the perspective of over 1,000 childbearing women, the reviewers concluded their finding with the following concept. Quote, the midwife-woman relationship is the vehicle through which personalized care, trust, and empowerment are achieved in the continuity of the midwifery model of care. End quote. And so through the midwife-client relationship, clients reported feeling at ease with the midwife, stating that the midwife always seemed present in the conversation and that they facilitated open communication and worked in partnership with the client during their care. The review reported that when midwives provided care through positive affirmations and, quote, enabled the woman to take lead in decision-making about the care provided, end quote, clients gained the needed confidence to, quote, grow and birth and parent her baby, end quote. And so you're thinking to yourself, geez, Caroline, that's really great. Well, what does this have to do with rural Texas? So far, you've only mentioned one study that looked at Texas. Well, getting to that. Uh, there was another cohort of authors, and it wasn't the Miss authors, it was a different set of authors, but they created a scoring system and used state policies on specific aspects of reproductive health to rank the states on a scale from 0 to 5. The higher the score, the greater the access to reproductive care there is, and vice versa. Texas was scored in the middle, along with 19 other states. And the researchers found that states in the lower and middle tiers had higher rates of preterm birth and low birth weight than states on the higher end of the tier. And so through this study, the researchers found a strong correlation between the state's policies regarding reproductive care and maternal infant outcomes. The more restricted access a client faces, the greater risk that the client and child will experience an adverse event during the periods of pregnancy and birth. And again, these are my own personal statements, but it can be assumed that due to the overturn of the 1973 decision in Roe v. Wade and the subsequent implementation of Texas House Bill 1280, that the rates of low birth weight and preterm birth, as well as the rate of maternal infant mortality, may increase in Texas throughout the upcoming years. And even with that, despite having some restrictive reproductive autonomy laws and being one of 11 states that impose supervisory practice agreements on midwives, the utilization of midwives has not slowed down. And so I must reiterate, it's nowhere near the national average, but midwife-attended births in Texas have increased by over 70% in the last year. And this is in spite of Texas seeing more than an 8% decrease in births from 2007 to 2021. Numerous studies in this review claim that an increase in midwife-attended births is associated with a decreased use of CD, or cesarean delivery, sorry. And this claim can be supported by the fact that in rural Texas, cesarean deliveries have decreased by 37% between 2007 and 2021, and midwife-attended births have increased by 78% between the same years. Again, this is in rural Texas. And so, as concluded earlier in this review, because midwives do not utilize cesarean deliveries and other medical interventions a quarter as often as physicians do, midwife-led care is relatively less expensive than physician-led care. Rural Texas patients who had a physician-attended delivery in 2021 spent in total about $28.9 billion. If 5% of those patients had a midwife-attended birth, and an estimated $9.32 million in savings would have been generated. And these prospects of projected savings would be appealing to anybody, but the option for out-of-hospital births is unattainable to many people due to the constraints set by insurance. Many rural clients really cannot afford the out-of-pocket expenses for midwifery care, with 72% of rural people being uninsured. And so without the further research into rural midwifery and state level stakeholders passing legislation to increase rural access to maternity care, many clients may just be able to be forced to accept care by entities that only really know them as a policy number. And so, sorry, my throat's a little dry, but So this presentation really serves as a comprehensive review of the improved client outcomes of midwifery and the institutionalized barriers in increasing access to midwives, and applies these two concepts to current day rural Texas, as I've been talking about. And so just to reiterate, births attended by midwives have a decreased risk of experiencing interventions and complications, thus leading to the average cost of midwife-attended births to be significantly less than that of physician-attended births. The combination of the decreased cost and risk of complications, along with the unique relationship between a midwife and their client, contributes to overall client satisfaction and empowerment. And studies have shown that, however, that states that regulate midwifery practices through non-autonomous frameworks result in fewer midwife-attended births and increase the incidence of adverse maternal infant outcomes. So implementing changes to increase access to maternal or midwifery services in rural Texas could result in increased incidence of physiological vaginal birth for low risk pregnancies and increased time and resources for moderate to high risk pregnancies. The midwifery model of care is a sustainable, confidence building avenue of maternal care that should be expanded into rural communities. As there is more of a lack of available physicians and maternity units, midwives resolve this issue due to their mobile and non-pharmaceutical oriented style of practice. So bringing awareness to the benefits of midwifery in rural communities and dissolving the barriers of practice could improve maternal infant health outcomes, not only in rural Texas, but the US as a whole. Now, in the to be published version of the review, I primarily bring attention to the lack of research on certified professional midwives and how to potentially fill this gap. Now, you may be thinking, but Caroline, didn't you say that Texas has, licensed midwives or certified professional midwives? You're correct. I will say with that, though, while CPMs are regulated in 37 states and then certified midwives are only regulated in 11 states, plus DC, pretty much every single study I found grouped midwives into either the CNM or the CM category. And I really couldn't figure out why. There are more states that allow the practice or regulate the practice of certified professional midwives than just certified midwives. So I really couldn't understand where the disconnect was. So for future research, I think should compare the maternal infant outcomes of certified professional midwives and collect more data on this severely underreported classification of midwives. And I think that such research can be spearheaded with a call to update the current birth certificate, which really to include more options on the birth care or the birth attendant. So far in Texas, it's just certified nurse midwife and other midwife. And it's like 4 different kinds of midwives could fall into other midwife. And so I just think that would help, create consistency and unity that I think the healthcare profession requires. The need for more research on uncertified midwives should prompt researchers to explore the practices and practicality of this subclassification of maternity care providers. And then policy, my favorite thing. Not gonna lie, I really do like policy. National policymakers, I believe, should allow representatives from midwifery organizations to join the discussions about midwives to create and implement a national midwifery model where all states regulate and classify midwives the same. Having consistent laws and regulations between states would support the need for universal healthcare in the U.S. And I believe that this should be a top priority to policymakers. That's just me. By unifying states through not only midwifery practices, but also the work of advanced practice, I believe that we would be able to achieve significant improvements in the nation's overall health. And so through this review, I also support the need for policymakers and funding organizations to pass legislation that allows advanced practice RNs to have full practice authority, thus have CNMs be regulated in a more autonomous framework. I think in future sessions, members of the Texas Congress should utilize the evidence collected when drafting and voting on legislation with the prospects of expanding rural Texas healthcare. And more of the institutional level barriers that exist, I feel like would take a little bit longer to reform. Individual obstetric care providers can support the integration of midwives into the maternal healthcare system by both midwives and physicians educating themselves on the other's respective models of care or scopes of practice. Physicians can improve their clients' quality of care by recommending midwifery care to lower risk clients, which thus allows the physicians more time to build relationship and care for clients for whom midwifery care is not recommended. So those moderate to high risk clients. So in an overall little conclusion, as I've stated, midwife attended births are more cost effective and have a decreased risk of labor and delivery interventions. They come with increased rates of client satisfaction and empowerment, and an increased incidence of vaginal births in low risk pregnancies, and the increased implementation of midwifery-led care can increase these wonderful benefits while also increasing the amount of specialized resources for higher risk clients. And I feel like this overall in turn could improve not only the state of health in rural Texas, but just the United States as a whole. So bringing awareness to the benefits of midwifery and dissolving the barriers of practice would really just, in my opinion, make things just a little bit better. And so that's it. Thank y'all. That's the center's contact information. I really appreciate y'all coming and listening to me talk a little bit about it. There's are all my references, but I am going to pass it on to Aspen, who's going to throw up the code and everything. And we can, talk a little bit, chat. So.
Thanks, Caroline. I'm going to put up that code now. Let me just double check that I think everybody has access to where they can turn on or turn off their mics. Give me 1 second. Yeah, so you all have access to turn off the mics if y'all have any questions at this time. Caroline, there was Renee Warren. She did comment on slide 16 and said that there was an open text field to indicate the type of caregiver on birth certificates in Texas, but access might be limited where the birth certificate is completed.
Hi, Renee. So that is interesting. I didn't know that. So where I got the information on the birth certificate data was from the CDC's Wonder tool, which I was able to extract data on, pretty much all birth certificates in the United States. And when looking at, the extraction tool, and you could sort by birth attendant, I had only really seen the certified nurse midwife and other. And I mean, there is that other category in general. So maybe on the actual birth certificate itself, it could be someone like great grandmother or second cousin. But through the CDC's website where I pulled the data from, it had only presented it as other. So that is interesting to know, though, and I appreciate you letting me know that that is actually an option. So. And then, yeah.
And then
So
Amy.
really great presentation. And I'm Renee Manhorn. I'm the PhD program director. So, we would love to see you consider continuing your education. But beyond that, did you assess bias in the literature you reviewed? Specifically, what I'm wondering is, was it written by nurses, nurse practitioners, or were you able to look at that?
Yeah, I was able to look at that. There were a few just articles that I can pick off the kind of the top of my head. I'm saying that in air quotes. I do remember seeing that, doctors of nursing practice had written some articles, actual CNMs, people who were in the nursing field had written a majority of the articles. And I will say that there were actually a couple articles that I didn't include because I had looked into the person's history a little bit more, and I was like, oh, it felt kind of biased, but I'm sure that I could have done a little bit more of an in-depth analysis. But with what I had at the time, I did do my best to ensure that the articles that I presented had a low risk of bias. Yes. Yes.
I just wanted to say that you did a fabulous job, and from a certified nurse midwife who does practice in a birth center and in the hospital, I think you described it perfectly. And I just wanted to say thank you for all your research.
Oh, thank you. No, just thank y'all for the kind words. I really did put a lot into this. I like I said, I started this process back in January of 2023, and it's been 2 years now. So I am really proud of what I have written and created. And, I'm just hoping that this is one step forward into, improving maternal infant healthcare in the United States as a in general. So.
Well, I just personally want to say thank you to Caroline. She has put so much work into this and so much time, literally blood, sweat, tears, it feels like. So I really appreciate everything that you've put into this. And the center is just so proud to be able to have this in the upcoming journal. So if anybody has any additional questions, I'm sure that Caroline would not mind sharing her information with y'all. If y'all want to talk some more with her. I know that somebody had asked to share the references. I will drop the PowerPoint itself, or Caroline, if you'll drop the PowerPoint itself into the chat so that y'all can have access to that. And then if anybody has any additional questions, y'all can reach out directly to the center and we can put y'all into contact if you don't have Caroline's direct information. So thank you all for joining. I'll give you about 20 minutes left in your day. Please remember to fill out the contact our QR code or the link. I dropped the link in the chat as well. And if y'all have any additional questions about that, you can contact Dr. Sharon Blackerby directly. Here's her email. Or you can reach directly out to the center and I can connect you as well. Y'all have a great rest of your day.